Hello everyone, I'm going to talk about the elbow today. So the elbow mainly consists of three bones, humerus, radius, and ulna. Okay, so if you're looking at your hand, the radius always goes inside your thumb. Okay, ulna is always the outer side. The radius rotates around the ulna, just know that. And then your humerus is obviously up top. Articulation. Okay, so for the flexion and extension, the articulation is going to be obviously the trochleae, okay, the distal humerus, okay, with the trochlear notch, which is the proximal ulna. Okay, so the trochleae you see here, okay, on the humerus, okay, distal part, and then the trochlear notch is almost kind of like hook around it and kind of form. So when it's fully extended, it's kind of like lock in place. That way you get this nice solid end feel. That way you really can't hyperextend past that. Okay, supination and pronation, which is this movement right here. Okay, remember this is supination and this is pronation. Okay, it's the head of the radius and the capitulum. Okay, which is part of the ulna. Okay, right here, not this part, on the ulna side. Probably in the next few pictures. So the supination pronation isn't not any part of the humerus. Okay, I know it says capitulum here. It is more part on the ulna. So there's no articulation with the radius and the humerus. So normal flexion extension is about 145 to 155 degrees. Okay, give or take on the individual. Pronation supination is usually 90 degrees. Each direction, roughly 170 to 180 degrees total between the full supination and pronation. Okay. A lot of people have a lot of restrictions, blocks, as a result of injuries or just development, capsular tightness, and so forth. Some have like absurd amount of range of motion. Here is a description of what I said, like the ulna and the humerus, how this kind of like seed just kind of attaches in there. And it kind of, when it's fully extended, this distal part just kind of locks in place to prevent that elbow from really going farther than it should. This gives that kind of bony stability for when you're in full extension that the knee does not. How the radius acts, so the rounded concave head for rotation, okay, so this is the radius right here, this is the ulna, and this is the humerus, okay, so the ulna, okay, so all right, going back a little bit, the radius rotates around, so the head of the radius, okay, hence rotates around the ulna, okay, there's a little bit of articulation here just because it a little bit touching, but it does not have any effect on the flexion or extension component. Ligament-wise, which is the more important factor here. Okay, so this is the medial view. Okay, so we have the ulnar collateral ligament. Okay, this is a really, really popular big ligament here. Okay, we have both the olecranon bursa. Okay, which is this fat pad on the tip of the elbow. That's kind of like an anti-friction pad. Really, really important. Can get inflamed if you lie on your elbow. It can get really pissed off and inflamed and get really, really swollen, both painful and pain-free. And a lot of times you'll go and drain it or inject some kind of steroid in there to kind of minimize that. We have your annular ligament. Okay, so the annular ligament here kind of wraps around the radial head and kind of keeps that in place. Okay, really, really important. You don't see too many injuries that involve or injuries to the annular ligament unless it's kind of forced supination or pronation. Let's see, the medial epicondyle or medial condyle, however you want to refer to it as, is that kind of bony prominence that sticks out. Okay, right here medially. And that is where the UCL or ulnar collateral ligament attaches to. Sometimes you'll see the ulnar collateral ligament referred to as the medial collateral ligament or MCL, very similar to as in the knee. On the lateral view, okay, obviously we have the lateral epicondyle or lateral condyle. Okay, we have the radiocollateral ligament, which is not injured too often. I've seen maybe one or two RCL sprains. A lot of them are going to be the UCL. Okay, just because the mechanism usually they're throwing, it's under a lot of tension when you're in this motion throwing. Okay. First, the RCL, or often referred to as the LCL, the lateral collateral ligament, okay, isn't really affected too much. Okay, only under some kind of absurd, like weird trauma where the arm may get caught and there's a force that comes more medial lateral. Obviously, a lot of this is encased within a joint capsule. Here is the lateral side of the annular ligament. As he kind of wraps around the humeral head. Just so you know, to point out, here is the bicep tendon. Okay, that attaches down here on the radius. Okay, down in here, and that gives out a good angle of pull. Let's see, go back a little bit. The UCL or MCL of the elbow, okay, does a really good job at the valgus stress. So a lot of time you'll see in baseball, pitchers really care about their UCL ligament because if that damages, their season's done. Okay, it used to be a career-ending injury way back in like the 60s. Nowadays, it is called the Tommy John surgery, is for that reconstruction, and that's usually only out about year and a half from that pitching motion. I'll go about Tommy John's here in a little bit too. All right, elbow flexors. Okay, so there's three main ones. Okay, there's your biceps brachii, okay, which is obviously the main biceps muscle. You have a brachialis, okay, and then your brachioradialis, okay. And so they're activated in different motions. If you're in full supination, okay, that is where you get the most activation of your biceps brachii. If you're brachialis, you're in pronation, okay. So if you're pulling up something like this, that is your brachialis. Your brachioradialis, okay, is in a more neutral position. Okay, and that's going to be like your hammer curls, okay. And your brachialis is more almost down your forearm a little bit. You may see, if you work out a lot and you're doing like the easy bar, which is a bar usually for like bicep curls that comes and then makes this weird like zigzag motion here. Put your forearm to about a 45-degree angle, okay, when you do bicep curls, and this activates, your biceps and brachioradialis a considerable amount. So that's why it puts that in that good position. A lot of people don't have the flexibility and the muscle activation to do straight biceps brachii curls in that open position because they lack the kind of flexibility in their forearms for the activation. So if you're working out your arms, really, really important to kind of hit all three of these. They're all different muscles, and they should be trained pretty evenly for the most part. Tricep-wise, okay, so tricep, okay, tri means three. Okay, so you have three heads of your tricep. Okay, there is the long head, lateral head, and medial head. Okay, important to note, the long head attaches to your scapula. Okay, so that helps to do that kind of adduction and shoulder extension. Is really that long head. The lateral head and the medial head all attach to your humerus, and those primarily do that elbow extension. You also have another muscle called your anconeus, and this only does terminal elbow extension. So that only does pretty much from here out, this last little bit. Okay, and it's that little muscle as you see here. Okay, really, really important, especially for that last little bit of extension. But usually you don't have too many issues with it, ever. Nerve-wise, going through your elbow, you have your ulnar, medial, and radial nerves. Okay, the radial nerve is kind of like that lateral elbow. The medial, okay, kind of comes up through just underneath your supinator. And the ulnar, okay, which is really common for your funny bone, That's where the one you kind of hit just kind of in there, and it just gives like the zingers. Let me say you hit your elbow and hit your funny bone. You're just kind of contusing that ulnar nerve. That's all it is. And a lot of time when they do like Tommy Johns, they'll actually move the ulnar nerve, depending on the type of surgery that they do. All right, UCL sprains. Okay, so the etiology, some kind of valgus force due to overhead movements, usually acute or chronic, can cause sprains in the UCL. Sorry, the picture is not the best. UCL relies on tricep, wrist flexor, the peroneal teres muscles, and the conus to provide that kind of dynamic stabilization for throwing. So you got to train all those different muscles to really help you with that stabilization part. Okay. So signs and symptoms of sprains to the UCL is pain on the medial elbow, which usually increases with any kind of motion. You can have possible radial nerve compression and ulnar nerve stretch, just because when the UCL fails, it usually resolves in stretching. I think it's longer than like 7% of the long. Sorry, 7% longer of a stretching to the UCL results in some kind of sprain, which can also put increased tension and a kind of stretch injury to the ulnar nerve or radial nerve, depending on whatever the force is. And pitchers is a big one because they're coming here and then forwards, and that kind of stretch motion on the UCL kind of also increases that kind of ulnar stretch, and so they'll have not only pain in the elbow, but like numbness going down their arm and hand. Other UCL signs and symptoms, okay, pain on medial aspect, okay, the P explanation, that's just shorthand for pain. Tenderness over UCL, paresthesia, and valgus stress test, which is just you're putting the elbow into like a valgus stress, to looking for any kind of laxity and pain, okay, which they shouldn't have any laxity, which usually you would refer to them to their orthopedic or gen med to get further evaluated for a UCL rupture. UCL injuries or sprains, okay, you want to treat them with any kind of modalities really for pain. Rice, really, you want to rest it. Ice it a lot for pain, really short-term pain, but still pain. Compression can help a little bit. Elevation only if they have a lot of swelling. Okay. Range of motion and rehab are really key items here. So the UCL rupture, the grade 3, which is a pretty common one, requires orthopedic referral for diagnosis. The often return is the Tommy John surgery. They're going to have really a lot of instability with it and a lot of pain. So post-surgery recovery is about a year, usually a bit longer, really to be really beneficial. Even though the recovery is about a year, to be throwing to adequate spread about a year and a half, because now they've got to build up all that muscle that they've lost. And that's a really bad thing about it. So the UCL and the ACL are usually going hand in hand, where it's a rupture of whatever the ligament. Surgery is usually pretty quick, pretty common nowadays, but then getting everything to recover takes a long time. So this is a little bit on the valgus force with the throwing motion. Okay, so you get your wind up, your early cocking, and then the late cocking to acceleration. That's the force that is the time where the most valgus force is placed on the UCL, and this is usually when that rupture occurs. So you're cocked back, okay, and then now your arm is still going back, and then your chest is starting to go forward. And so that puts you in that external rotation, okay, and you're trying to get that whip, okay, on your arm, okay, and that's what puts more of that valgus stress on there. Some people are more prone to UCL ruptures than others, and there's a variety of reasons for this, both intrinsic and extrinsic forces. For the Tommy John surgery, they'll actually take, excuse me, a reconstruction. They'll make this kind of figure 8 in here. So the popular one they'll use is the flexor palmaris longus. This is your forearm. Now, I think it's only like 28% of the population actually has this. So if you do opposition your thumb to pinky and you go down, so if you see like kind of tendon that pops up, that means you have it. Okay. Some people have it. Most people don't. It's just an extra muscle in your forearm. Having or not having it doesn't really mean anything. Some people that have it, they may have it in one hand versus the other, which is kind of weird. And just a thing that happens. So what they'll do is they'll take it out. You see here, they'll measure it out. They'll make 2 incisions here. They'll pull it out, and they'll use it to do the reconstruction. Now, in the module, I believe I'll have either 1 or 2 actual surgeries, so you actually watch it all, which is actually pretty cool. The RCL sprains, or radial collateral sprains, are pretty uncommon. The forces just aren't there for a lot of different reasons. So you're not going to see too many of them. You're going to see a lot of contusions to the elbow just because of where it is, especially in contact sports. Rugby, football are the big ones. And also on the elbow, because there's not a lot of tissue, okay, you just straight bone here, you're going to get a lot of those kind of bone contusions. And you get a lot of buildup as a result, like myositis ossificans, which is kind of buildup of that bony formation in the elbow. In football, they call it blockers, exosis, or whatever it is. So it looks kind of like this, where you see this kind of bony buildup. And always is that's that your wherever that contusion is, and all that blood kind of sits, that bone or that blood calcifies, and it pretty much forms a protective barrier, which your body just does naturally as a form of protection, but also it limits range of motion, it gets in the way, can form other issues down the line. It only really happens if it's not taken care of properly. Okay, so like you see like a lineman that's starting to get a lot of bruises on his arm, giving him just some extra protection like on the elbow can help out, prevent some of this. If it gets really bad to like this and worse, they'll actually have to go in surgically and remove it, which there's a lot of issues with that because you're taking out areas of muscle now that have become bone. So now you're going to lose some areas of muscle. They may have to go in and break them out depending on what it is. A lot of times these fragments can get inside the actual joint line and cause worse issues. All right, fractures on the elbow can also be pretty common. Big concerns are nerve, artery, and vein because it's all travel just alongside the bones. So any kind of sharp fragments can puncture or damage any of those, which can cause substantial injuries down the line. A lot of time the history is going to be, I felt the pop, crack, weird sensation. A lot of time with a fracture, you'll have a posterior elbow dislocation. A lot of time that goes hand in hand. Okay, you see some of the fractures here. Okay, and obviously here where it should be. Fractures in the elbow, you should really kind of split them as found. Okay, really, really important. Okay, don't try and maneuver them because you can cause further issues. Humeral fractures are really common, especially in adolescence. Okay, especially on the condyles during the growth spurts. You can see a lot of them just because during their growth spurts, their growth plates are developing and they're really kind of weak. And so during the ones on the condyles, if they're doing a lot of pitching, especially more than they should be, you can have a lot of kind of avulsion fractures as a result there. Okay, so elbow dislocations. Okay, obviously this is a great one right here. Can be pretty common, usually pretty extreme for the most part. So elbow dislocations and elbow fractures, or just any kind of fracture in the hand, wrist, forearm, going up to the shoulder, are as a result of a Fuchs injury. okay, which is fall on outstretched hand. Okay, that's what a foosh is. It is the number one way to kind of get that that injury. You're gonna say, "Oh, he fooshed," and I'm like, "All right, that's easy." So you'll fall on outstretched hand because you usually trip, fall, whatever it is, and you put your hand up to slow yourself down. Okay. As a result, all those forces are applied to the weakest area, and that area usually gives. So posterior elbow dislocations are the main way of the dislocation. Usually results in some kind of hyperextension. Okay. Most common directly is the posterior lateral. Involved injury to most ligament structures and some neurovascular. Most present with subsequent myositis efficans, as I mentioned earlier. Once a dislocator, always dislocator. That's really important to know. And I can't really do a lot about that. As a result, that's just how it happens. So once they dislocate, they're much more prone to it for the rest of their lives. Even if they do like capsular tightening or whatever it is, still over time, it's going to go back to that loosened state. And I've seen elbow dislocation. I've seen a pole vaulter dislocate his elbow after he let go. So after he threw himself away, okay, that dislocated just during that. I've seen soccer players dislocate their elbow from just running. Okay, and an athlete that it was a chronic elbow dislocator just from that excessive running motion. Okay, so that one can be pretty common. Here's the bursitis I mentioned earlier with the bursa. Okay, it gets inflamed due to usually direct trauma as a result. And it gets, this is a pretty mild one, but usually it can get pretty big on this entire region right here. And they usually just go in and drain it. I wouldn't try and drain it on yourself just because of the higher risk of infection if you do that. Let a medical professional do that. A lot of times they'll just like leave it be and it'll kind of disappear on its own, or they'll inject the steroid in there to calm it down or whatever the need is. Epicondylitis. Okay, so this is a common one. This is a degenerative condition of the wrist extensor tendon associated with occupational or sport activities, and involve usually some kind of repetitive wrist extension and forearm supination. Okay, so if the epicondylitis is lateral, it's often called tennis elbow, and if it's medial, it's called golfer's elbow. Okay, so here's that epicondyle right here. So here is where let me make sure. Okay, lateral and medial. Okay, so the medial one is where all your wrist flexors attach into. Okay, right in here. And the lateral one is where all your wrist extensors attach into. Okay, so depending on where the excessive motion is, usually it's pinpoint on that motion. Okay, the lateral epicondyle on the outside. Okay, it's usually associated with like tennis athletes, but doesn't have to be. A lot of golfers can get that lateral epicondylitis pretty commonly. Just the latter one's just more common than the medial. So common muscle associated with lateral epicondylitis is the extensor carpi radialis brevis and extensor digitorum communis. Okay, deep in here. So all these will attach to the lateral epicondylitis up in here. Common muscle associated with medial epicondylitis is peroneal teres, flexor carpi radius and ulnaris, and flexor palmaris longus. And it's always some kind of repetitive microtrauma, okay, or overuse for either one of these. Okay, so you have pain on lateral medial, with either wrist extension or wrist flexion, and it gets resistance. Okay, you have weakness, tenderness, pain during and after activity. Pain on active and resistive flexion and extension of the wrist. Pain with the resistive extension of the wrist and full extension of the elbow. And you have a decreased range of motion at the elbow as a result of all these. You got to think some of these muscles do all like their flexion and extension here, okay, as well as here. For example, the muscles that do your finger flexion also attach there. Same with wrist flexion. So what if you're doing wrist flexion and extension at the same time? Okay. So some of those muscles have to contract and others have to elongate at the same time to do this motion. Okay. Because all the muscles here and here attach, but what if you're doing two opposing muscles at the same time? Okay, if that makes sense. So treatment of epicondylitis is usually conservative. Okay, anti-inflammatory or NSAIDs. You can do ionto or phonophoresis. These are more modality usage items where use of some kind of medication. Cross-friction massage can be really good. Also really painful because you go in and you kind of perpendicular to that ligament do a really deep, intense cross-friction to kind of irritate it. What the irritation does is it promotes blood flow to the area to help with healing. But it's one of those that's going to get worse before it gets better kind of thing. And it usually takes about 1 to 2 weeks for you to fully recover from that cross-friction. Stretching is really good, especially if done early and pain-free. Strengthening is also really good of all of that surrounding musculature. The lateral epicondyle is really kind of aggravated because there's a big muscle imbalance, especially from your medial. Because your medial has all your wrist and finger flexors. Excuse me. So it's usually really, really strong. But a lot of time you don't really exercise your extensors. Period. Okay. So usually that muscle imbalance is all your extensors have to counteract all your flexors, which are usually overactive as a result of gripping, doing anything like that. So a lot of times strengthening your extensors is a good idea, but maybe you need to relax your flexors, okay, to give that full relaxation to the extensors, if that makes sense to everyone, okay. The counterforce brace, as you see here, is just that brace that kind of goes, and all it is just to help redistribute the forces, okay. You can buy the commercial one, or you can use some kind of pre-wrap in there. It works for some people, and it doesn't work for others, okay. Epicondylitis is easier to prevent than to treat. Okay, and some of the newer thing is they're using the platelet-rich plasma injections for some of these. So all it is they're taking about like 500 cc's of your blood. They'll extract it. They're going to put it in a centrifuge and spin it. And then what it's going to do is going to force all the red blood cells to the bottom, and at the top half of that that vial is going to be all the white blood cells, the platelets, the hormones, and everything else. I'm going to take that area and inject that deep into the tendon. And then it's going to try and help with some of that healing because you're going to get all the hormones for healing, the white blood cells, the platelets. That really helps with all that really, really important stuff without injecting all this extra red blood cells. It's pricey. It's very, very safe. The worst thing you got to deal with is possible infection from the injection site, like any normal penetration of the skin. See, I took out all the special testings for the elbow just because it's not, I don't want to really include a lot of that in this course right now. But that is the main thing for the elbow, kind of a little introduction. Really watch the videos on the surgeries. It gives you a little bit more in depth on how that kind of happens. And that is it.